Hello, and thank you for standing by. Welcome to today's program, Chronic Graft versus Host Disease webinar. Let's learn from the experts. At this time, all participants are in a listen-only mode. A question and answer session will follow the formal presentation. You may ask a question at any time by typing it into the Ask a Question box on the left side of your screen. As a reminder, this conference is being recorded. It's now my pleasure to turn the call over to Peggy Burkhardt. Please go ahead.
Thank you, Kevin. Thank you all for joining us today. My name is Peggy Burkhardt, and I'm the Executive Director of the National Bone Marrow Transplant Link, and I'm just thrilled to be your host today. We're so excited to bring this cGVHD webinar sponsored by Incyte Corporation and Pharmacyclics and Jensen. And of course, we could not do this without our link partners. They play a very important role in all that we do. So today we'll be sending a very brief survey out to all of you in the next few days, and we hope that you will help us help others by filling it out. So thank you in advance for that. And we sure hope you get a lot out of this webinar today. First, we will have Dr. Connie Sizemore, who will lead the discussion today covering the increase of allogeneic transplants, the grading process, risk factors, and how the skin, eyes, and lungs are affected, and treatment options. And then we will have Dr. Don Stackheart, who will cover the emotional support for those transplanted. In particular, we'll focus on chronic graft versus host disease today. Next, we will hear from Latasha Mccoy, who's a BSN RN, who will cover the signs and symptoms of GVHD and the benefits of a patient diary. And last, but certainly not least, you will meet Lisa. Lisa Lotzenhiser will share her survivor story and how she deals with her chronic graft versus host disease in sunny California. Then we will have time for questions and answers, and Kevin and I will field the questions together and try to answer as many as possible today. First, a little bit about the link. There you can see my picture to the left and our Jennifer Gillette to the right. We are a patient advocacy group dedicated to helping individuals and their families navigate the bone marrow stem cell CAR-T journey from beginning to end. We work with hospitals and transplant centers to reinforce and complement medical care by providing resources, support, and education. We link you to experts from across the country on many topics related to transplant and also to others who have taken this journey before you. Here's our contact info, and just know that we love to hear from you. Even if it's just a quick email, it makes our day. So please feel comfortable reaching out to us at any time. Our emails are listed. And also visit our Facebook page. We would love to have you guys as likers of our page, and we post daily. Jen does a great job for us on that. And so now I want to thank again our sponsors, Incyte Corporation and Pharmacyclics and Jensen. And now we're going to talk a little bit about you can see here the resources that we provide, and then we're going to get back to our medical disclosure that anyone can read when the time is right. And then I'm going to introduce Dr. Connie Sizemore. Connie Sizemore is a clinical pharmacy practitioner with the Northside Hospital Cancer Institute Blood and Marrow Stem Cell Transplant Leukemia and Immunotherapy Program in Atlanta, Georgia. She has been with Northside for what I believe to be about 15 years. She has tons of experience, and I'm not going to sit and read through her whole bio, but we are so lucky to have her here today to speak to us about chronic graft versus host disease, and I know that you're going to love what she has to say. Next, we have Dr. Don Stackheart, who's been with Northside for more than 20 years, and she is a clinical health psychologist for the Blood and Marrow Transplant Program. She received her doctorate from Indiana University, has been working, like I said, for over 20 years. She's going to focus on psychosocial factors that impact transplant outcomes. And next, we have Latasha Mccoy, who is a BSN RN, and she has been with Northside. It looks like she started in about 2015, and we are going to hear some wonderful stuff from her as well. And I'm just not going to read through the bio, but it is there if anyone would like to at a later date. And last but not least, we have Lisa Lotzenhiser. of California, like I mentioned, 58 years old, and she is a mega survivor. We are going to hear about how she manages her life, her beautiful daughter. She's a newlywed, and she is a teacher out on disability who misses it a lot, and she loves to travel, read, work in the yard, and she's going to just make us all feel so good on how she handles all of this. So without further ado, I would like to turn this over to Dr. Connie Sizemore.
Thank you, Peggy. So I'm going to talk with you guys for roughly 30 minutes or so, and the focus of my talk is going to be on allogeneic transplant. What does it look like beyond 180 days? I like to start the conversation with you about looking at the number of allotransplants, how the number continues to increase each year. This is from the CIBMTR registry that is a registry bank that maintains data on all patients that have been transplanted. And you can see here that the allogeneic transplant still remains to be the highest as far as between allo and auto, but our allotransplant number continues to increase as well. So along with that, we would have an increased incidence of graft versus host disease in the patient population as well. There are known risk factors for graft versus host disease. If you have had a prior acute graft versus host disease episode, particularly grades 3 or 4, this increases your risk of having chronic graft versus host. If you have HLA disparity, and I've listed here in the order of the incidence of the severity increases with the disparity. So an HLA matched related donor compared to an HLA unmatched related donor, the unrelated donor would have an increase in severity. A mismatched unrelated donor will have a higher chance than a matched related donor. We do know that the stem cell source is also a good predictor of whether or not a patient would have graft versus host disease. Those patients that have been transplanted with peripheral blood stem cells have a higher incidence than bone marrow. However, it is common practice now that most transplant centers are transplanting with peripheral blood stem cells because you do get a better engraftment with the platelets as well as a robust white cell engraftment because you have more stem cells that can be transplanted versus retrieval through a bone marrow. Older patients as well as an older donor age increases as a risk factor for graft versus host disease. The donor lymphocyte infusions increases your risk. Sex mismatching. So if you receive cells from a male receives cells from a female, that would increase the chances of your chances of having graft versus host disease. And then conditioning intensity. This myeloablative has a higher incidence than your reduced intensity versus your non-myeloablative. This makes sense because with your myeloablative transplant, you have a much more cell death, whether it's mucositis or your stomach lining would be disturbed, as well as a lot of these myeloablative transplants have total body radiation that's given. So you have skin cells that are damaged, and that is the reason why it's the thought that conditioning regimen does increase if you have a myeloablative, you do have an increased risk of chronic graft versus host disease. So let's talk a little bit about defining graft versus host disease. I'm going to try to make this on a simple level for you because it is hard to understand. I mean, you've got donated stem cells that are transplanted. These stem cells also have T cells you have stem cells as well as T cells from the donor. T cells, they are a type of white blood cell that does protect the body from infection. They recognize what belongs in the body and what is foreign and potentially dangerous. For example, T cells, they see bacteria and viruses and fungi, and they know that those are harmful. So it helps to defend itself and fight off a bacterial infection because it recognizes that it's not self. One of the benefits of an allogeneic transplant is that your donor T cells recognize foreign cells from the patient's cancer cells that have survived during the conditioning regimen. And this is what we refer to as graft versus tumor effect. It's where these T cells identify potential cancer cells that have not been, that remained after a conditioning regimen. They recognize that as non-self, and they attack them and eliminate them. This helps prevent cancer from relapsing. This is called graft versus tumor effect. When the immune system is working normally, it helps to defend the body from against harmful invaders of the virus and bacteria. However, this is what helps you to stay healthy. But in chronic graft versus host disease, these donor cells see the body as a threat, and they attack. So you could get an attack on your own immune system if the cells don't exactly recognize the difference between something that is harmful versus something that is self. So this is where we get the graft attacks the host. Graft versus host disease, it can be mild, moderate, and severe. As far as the symptoms, I've listed out here where we typically see signs of graft versus host disease. The skin, mouth, eyes, and gut, and the liver are the most common. You'll see here that with your peripheral blood stem cells, you do have a higher incidence of graft versus host disease over bone marrow stem cells. I like to show this slide when I'm speaking about chronic graft versus host disease because oftentimes there is a disability. It can be manifest itself in an array of spectrum of different organ sites, and patients can feel that they're alone. And I like to show this because you're not alone. I mean, there's so many patients that are struggling with graft versus host disease, and later on in this presentation, I'm going to talk to you a little bit about some of the newer therapies that are coming out. And I think it's often hard to distinguish, the outcome. How do we come up with an endpoint? Because you've had leukemia or lymphoma, and you have the symptoms of that disease, but then you get treated and you go into remission and you're getting a transplant to get a cure, but at the same time, you've got to be able to function and have a quality of life. And sometimes that's difficult for patients. And I think that's the advantage of you listening to podcasts or webinars like this, is because you can educate yourself and know what types of treatment options that are out there. The National Institute of Health has had many working groups, consensus conference groups that have been working on different entities of chronic graft versus host disease. Despite the progress, the algorithm for how we treat chronic graft versus host disease really has not changed that much since the 1980s. We have had newer treatment come out within the past 5 years, and I'm going to talk about some of that new treatment. But these patients, they're still suffering from some major limitation, and there's an urgent need to develop frontline treatments to help minimize corticosteroid exposure. But in 2020, there was a working group that was formed, and it's actually the fourth working group for the NIH Consensus Conference that meets yearly. And the focus of this fourth working group was to focus on highly morbid forms of chronic graft versus host disease. And particularly, they're looking at lung, the skin, sclerosis, and ocular disease, because these oftentimes they can be very uncooperative in nature as far as how well they respond to treatment. I wanted to quickly show you how we grade graft versus host disease, and I think Latasha is going to focus a little bit more on that. But it's important to know that graft versus host disease, there is a score, and it's graded based on that score. You're given an overall mild, moderate, or severe category for your graft versus host disease. Once you have a score, that determines what treatment is necessary. I've highlighted here the areas that I'm going to focus on, as well as the NIH consensus group, that we're looking at skin, we're looking at eyes, and then we're looking at lungs. And when we're speaking to the grading of the skin, I start here range of motion, because that's very important to know when you have chronic graft versus host disease of the skin, what is your range of motion that you have, and if it's progressing or changing at all. So I had mentioned earlier that there are different categories of graft versus host disease. For the mild, typically at my institution, if someone has a patient has mild chronic graft versus host disease, we typically try topical therapy. And then once a patient has progressed on to the moderate or severe, that's when we are looking to put them on more of systemic therapies. The first area that I do want to talk about is the lungs. Bronchial obliterans, it is a 10 to 15% incidence in those patients that have pulmonary complications after stem cell transplant. And the onset is rather gradual. It happens over a slow period of time rather than an abrupt. A lot of times these patients are having a cough and wheezing, and it just somewhat sneaks up on them. The way that it is diagnosed for the diagnosis is that we typically do spirometry testing here, and it's essential. When you're looking at a spirometry test, and I put a picture here at the very right corner of what that looks like, and the patient is asked to inhale air and then blow out air. And what we're looking at is we're looking to see if there is any type of residual air that's left in the lungs. If there is a fibrotic occlusion or any type of destruction in that lung tissue, then there would be residual air left in the lung, because it would be restricted, and that we call that air trapping. We also get a CT scan, a high-res CT scan, and a high-res CT scan, you can see here in this picture the areas where there's air that's trapped, because the bronchioles are dilated and they have become fibrotic, and they do not open and close like they should. And air becomes trapped in there. So the patient is unable to exchange oxygen properly, and they become short of breath. We do, for diagnosis, we also like to do a bronchial lavage, and that's the picture here that I have in the right bottom of the right-hand side, and that is a scope that is placed down into the lungs, and we actually get bronchial alveolar washing, and just to rule out infection. You do want to make sure that there's not an infectious cause that would be causing there to be trapping of the air in the lung. I do want to say that the biggest piece for lung bronchial obliterans syndrome is early detection. It's the key, and this is early detection is done through proper pulmonary function test. Most transplant centers have a pulmonary function test baseline prior to transplant, And then for each of your workups, you should be getting pulmonary function tests, and we look at that to make sure that there's not a decline. So early detection is the key to turning things around very quickly. I found this quote, and I like it because it says, patients with pulmonary GVHD often do not have symptoms until the disease has progressed. Periodic pulmonary function tests are the best way to catch lung GVHD and begin treatment early before the symptoms become severe. Once you have severe bronchiobliterans and the bronchioles are fibrotic, at that point you have no choice but to begin some type of systemic steroids, and as well as restarting a calcineurin inhibitor, such as your tacrolimus or cyclosporin. A gold standard, or what used to be the gold standard, first-line management, is a protocol called Pharm, and it's fluticasone budesonide, which is an inhaled corticosteroid, azithromycin, and Cellular, and then LABA is a long-acting beta agonist. This has always been a gold standard for a long time in transplant. I do want to touch a little bit about the azithromycin here. I put it in brackets because azithromycin, it is a antibiotic, and it's generally considered to be safe. In lung transplant, there've been studies that have shown that it decreases the risk of bronchiobliterans when given as a preventative, as a prophylactic medicine. There was a clinical trial that was conducted in France, and it was at a transplant center, and these patients were given because of the history that we know with lung transplant and preventing BOS, these were stem cell transplant patients that they were given it as a preventative to prevent BOS. This study turned out that it increased the incidence of relapse in this patient population. So an FDA warning did come out about azithromycin. The incidence of lung GVHD did not go down, but the incidence of relapse did go up. So the FDA did release this warning. Is it a concern? The thought process now, and there are clinical trials being conducted on using it late transplant, is that these patients, it's a different patient population. Most of your patients who have BOS after transplant, they are far enough out that the risk of relapse is, their BOS is much more of a greater risk than the risk of relapse. So the one thing that it did prove is that azithromycin definitely has immune modulating effects. So, there are centers that still use it. We do here in a patient that has BOS, and I think that there'll be more coming out on that. I anticipate that shortly for, clinical trials showing that utilizing it late transplant is certainly the right thing to do in a BOS patient. I'm going to talk a little bit about extracorporeal photopheresis, ECP. I'm going to talk a little bit about that later on in my presentation, as well as rituximab. That's another treatment option that is given for BOS. The thing I do want to mention is with BOS, it really requires a multidisciplinary team. Typically, it's involved with not only your bone marrow group as well as your pulmonology group and your ID group, because you want to be able to make sure that pulmonology is involved, because there are things such as pulmonary rehabilitation, supplemental oxygen therapy that's given. The infectious disease group is often involved because we're wanting to rule out that the patient doesn't have any type of bacterial infection going on in their lungs. We definitely want to keep these patients vaccinated for the flu, the COVID vaccine, And then psychosocial support is very important as well, because this bronchial obliterans can be very debilitating. So now I want to move on to the ocular graft versus host disease. The incidence is more common than bronchial obliterans. It's approximately 40 to 60% of patients with systemic chronic graft versus host disease will develop ocular. Typically, it's within the first 2 years after transplant. Oftentimes, these patients just have dry eyes. That's a hallmark symptom, but they can also be gritty, blurred vision. They could be light sensitive, have redness, burning sensation, a lot of mucus secretion, but especially early in the morning after sleeping, and then just this foreign body sensation. As far as the manner in which this disease develops, it's once again, it's the thought that there's an immune attack from the donor cells on the conjunctiva of the eye, and the conjunctiva is that thin, clear membrane that covers the eye, and the tear glands that are the lacrimal glands are also attacked. So the diagnosis for this is oftentimes dismissed because patients just think that they're just getting older, and they think that it's just common after transplant. So what we have started doing here at my institution is we perform a Schirmer's test prior to transplant. We do that, and then we, on each of their visits for their post-care, we look at a Schirmer's test. And what a Schirmer's test is that it measures the tissue, the tear production. It's a little film that's placed in the eye, a little slit of paper, and the tears, it measures the amount of tears, this is in millimeters, that are produced. You can see here what one looks like in the eye. They can be quite uncomfortable, especially in those patients that have severe dry eyes. Once you get down to hardly any tears being produced, oftentimes we don't monitor them as often, but they are a fairly decent indicator, especially for those patients that going into transplant, if they already have a low tear production, then going into transplant, it's nice to provide them some relief so that, like with artificial tears or something like that, going into transplant, so that we would have a better method of monitoring them post-transplant. So I've listed out here some of the ocular treatments that are topical therapies. This would be for those that are in that mild category. There are a lot of topical therapies that are available on the market, different categories, corticosteroids. We typically start, and we do high doses of this. We start the patients out with 4 times a day for the first 3 to 4 weeks, and we do recommend that you try the corticosteroids to calm down the eye because of the abrasions that can be there. The problem with the high doses of steroids is you do have to monitor intraocular pressures. So what we typically do is get a patient started, but then we send them to ophthalmology so that they can monitor the intraocular pressure for us. We use Restasis quite a bit. It is available as a commercial product as well as a compounded eye solution at 1%. This does cause burning of the eye. That's why it's a good idea to use corticosteroids first, because the corticosteroids do help to heal some of those lesions that could be on the eye. The cyclosporin, the vehicle that it is in, causes quite a bit of irritation. So we recommend doing the corticosteroids first, and to allow the surface of the membrane eye to heal, and then begin cyclosporin drops after that. Another product that's available is Xiidra. I feel like it doesn't work as well from my experience with our patients. It does help to reduce the inflammation. but I feel like that we've had better success with the Restasis product, the cyclosporin product. I do want to talk about another treatment that I like to use on patients as a topical treatment. It is serum autologous tears. They are quite beneficial, and a number of individuals that I've used them on. The way serum autologous tears are obtained is the patient's blood is drawn and it's spun down, and the clear serum that floats to the top is removed off, and the serum is taken to a compounding pharmacy, and it can range from 50 to up to 100% serum, and it's placed in a eyedropper, and it can be dosed 4 to 8 times a day. The serum really seems to work well, especially for those patients who have scleroderma lenses, and I'm going to talk a little bit about that coming up. I do want to mention that there are patients that do get blepharitis, which is where their eyelids become really inflamed and they start to slough off cells. And I have used Protopic, which is a topical tacrolimus on eyelids, because that's also a common thing that happens with eye, graft versus host. Here in this picture, I wanted to show you another treatment that we like to do. It's called Punctal Occlusion, and it's where a small device is placed into the tear, the upper and lower tear ducts. And this is tear plugging, because what it does is the tears that are left, it prevents them from coming out. This has to be done by an ophthalmologist. It is something that doesn't hurt, and typically they stay in about 6 months, so it does give us a chance to become aggressive with the treatment, and then the patients after 6 months, sometimes they don't need them replugged, because we have managed to correct the ocular surface of the eye, and their GVH has calmed down. But these do work very well to keep the tears that the eye is producing inside of the eye. The next type of treatment that we have found success with I mentioned them earlier, is the Sclera Lenses. Boston Sight was the first company that came out with the PROS device, and I have pictures here. You can see what exactly they look like. They do cover your entire eye. You do have a special device that is used to apply these device. The purpose for this is one, it promotes healing, because you're able to, you see here the shape of this cornea is very awkward shaped, and that's what happens when you have dry eyes, is the cornea does change, and it becomes very painful. So by taking this lens and putting liquid drops, whether it's Refresh or autologous serum, into these lenses and then putting the lens on the eye, it helps to heal the surface of the eye. It does give some type of mechanical support as well, because you do have the misshape of the eye because the eyes are dry. It also helps to protect the eye. You're putting this fluid in between to help maintain hydration, and so you're protecting the eye, you're giving the eye a chance to heal, and it typically covers the entire surface and covers up those nerve endings, and it does relieve quite a bit of pain that patients are having. I will say that you do have to have a center that specifically deals either with the Boston Sight lens or a center that can manufacture and fit you for those lenses. And we've got a ophthalmologist here that can do that. And most larger cities, I would think, would have the ability to be able to produce these lenses. All right, let's move on now and talk about skin. Your skin is the largest organ of the body. 80% of patients will develop chronic graft-versus-host disease have skin involvement. The onset for this is typically it's usually after the day 180 mark. It can present. It's different than what acute graft-versus-host disease, how it presented. Acute graft-versus-host disease is angry and red and itchy. This can be, it can look quite different, especially if it progresses to the scleroderma portion. It can damage the hair follicles, your nail beds, your sweat glands. It can get into past the subcutaneous layers into your deeper layers and cause skin tightening and fibrotic, and even into the joints. So this is quite different. The picture is very different than acute graft-versus-host disease. It's very important to know for the diagnosis a skin biopsy and know the amount of body surface area that's involved. And then once again, that range of motion is very important to be able to track. Let's talk about the therapy. First, we're going to talk about topical therapy. With the topical therapy, there are topical steroids. This would be a first-line therapy if you had mild GVHD of the skin. There are different strengths that are available. Hydrocortisone is over-the-counter, and this is what we use for our face. It's a very low potency, and you would never, ever want to use something that had moderate or high potency on your face or under in areas that have thin layers of skin tissue. After you apply topical steroids, emulsions are very good to use because they help increase the potency. An emulsion helps hold in that moisture and helps hold in, keeps the steroid intact on the skin. And what I mean by an emulsion, Aquaphor, is a very good emulsion that you can use. A lot of patients that even take saran wrap, and if there's a particular area, they put their topical steroid on, and then they do their emulsion, and then you can saran wrap to help keep the moisture in as well as get that the steroid to be able to penetrate. Tacrolimus, pimcrolimus, I've used that for lips and genital areas. You have to be careful with, would not want to use a high potency steroid at all on your lips. I've used clobetasol, which is a moderate potency on for genital area for short periods of time, but you would never want to use something that had high potency for a long period of time. Another therapy that works really well is phototherapy, UVA Uvb Light. And I'll show you over here the difference between your UVA UVB, the way that how it can actually penetrate to the skin surface, the epidermis and the dermis. And we actually have a dermatologist that we work with. We work very close with him, and it works well for patients. Looks like a tanning bed type apparatus, and it's UVA, UVB exposure. Massage therapy as well as physical therapy is another option for skin, especially once you have scleroderma that's set in. Physical therapy is very important to loosen up that skin, as well as to give you some exercises and things that you can work on at home. I put ECT down here again, and I think it's very, we use ECP quite a bit, and I'm going to talk a little bit more about that as a whole later on, because it's used in each of the disease states for chronic GVHD that I'm talking about today. I do want to mention that, once you have the moderate to severe GVHD, systemic steroids, as well as your calcineurin inhibitors, they are essential if you have the moderate to severe. You wouldn't be able to just use your topical therapy. So now we're going to talk about, I've talked about the lungs and the skin and the eye, which are the three focus that the National Institute of Health felt like that it's the most debilitating for patients. And that's why I wanted to talk about that today. But I also want to talk about what are the second and third line agents out there, like what happens after you have corticosteroid failure, what happens after you've tried topical therapy. Today, there is no consensus on the optimal second-line therapy. There are 3 drugs that have been approved from the FDA, and this is very exciting. These clinical trials are a very, small number of patients because we can't have 2,000 patients in a clinical trial because there's not 2,000 GVHD patients that would qualify. So there's a small number of patients, and sometimes the results are hard to interpret because because of that suboptimal sample size, and the treatment of choice really is based on, a lot of times it's based on the practice of the physician. It's based on the ease of use, the need for monitoring, and the risk of toxicity. And the patient has a choice for this because some of these drugs do need to be monitored more often. Once we put you on one, you may have to come in and get count checks more often, and maybe that's not feasible. So coming up with a care plan after that for that second and third line, it can be tailored to what the patient needs to be able to have in their life, because a lot of times these patients are already back at they've left and back at their referring. So the first drug I want to talk to you about is ibrutinib. This was the first one on the market that was approved for chronic GVHD after failure of corticosteroids. The overall response in this clinical trial was 67%, which we were very pleased with that. Keep in mind that, the number size is only 42 that were in this clinical trial, which is, like I said, that's a very small. But to have an overall response rate of 67%, that was incredible. As a result of this trial, the FDA granted it approval for steroid refractory chronic graft versus host. I do want to mention that the most common effect was fatigue and muscle spasms, and it can cause bruising, and because it can drop your counts. Ibrutinib, I wanted to show you here, it is dose dependent. It's dose based on the toxicities, so your dose may need to be adjusted from where you start, and then you're going to have to come in for frequent monitoring. So that may be something that a patient can't do. And if you can't come in for lab checks, then this may not be a good drug for you. But because it can, if you look over here at the adverse effects, platelet decrease, neutrophil decrease, as well as hemoglobin decrease, those are all, the percentages are listed out here. But however, there is dose, it is dose dependent. So you start out with a 420 milligram dose, and if you have effects of any of these adverse effects, the dose can be tapered down. But once again, this would require you having to go back to your referring for monitoring. The second drug I want to talk about that was approved, this actually was the second drug that was approved. It's Roxalip Nib, and this was in the REACH-3 trial. It's Jakafi, and this is for steroid refractory. These patients were, after being refractory to steroid, were placed either on Jakafi or their best available therapy, which could have been a calcineurin inhibitor, so they could have been on Prograf, but they are in steroids. And for this, these patients the study did allow a crossover after week 24. The patients that could cross over and join the Jakafi trial. I do want to mention that once again, we saw very good results from this. However, these patients do have side effects, and this drug does require quite a bit of monitoring because it can drop counts as well. What response that we saw from this was that 59% of these patients had moderate, because you had to have moderate or severe graft-versus-host disease, but 59% of those patients did see a response to an overall response. But this drug can cause drop in platelets as well as CMV reactivation. So it would require that you would need to go have frequent visits to your referent to have the blood counts checked. The last drug that I want to mention that was just approved back in August is Rezurock, and it's the first of its kind to be on the market for chronic graft-versus-host disease. These patients who were in this clinical trial had to have failure of greater than 2 prior lines of systemic therapy. Most of these patients were in the severe category. 70% of the patients who were enrolled in this clinical trial were in the severe category, and the majority of them had prior ibrutinib exposure, because keep in mind, ibrutinib came out 2 years ago, so that would have been a drug that most of these patients would have been on, and that they would have considered that as one line of therapy. So most of these patients had ibrutinib exposure and did not respond, and most of these patients were in the severe category. 30% of patients in this clinical trial had received Roxalip Nib too, so that would be considered a line of therapy. Okay, and as far as the overall response here, we saw, this breaks it down. I love this slide because it gives you a good view of what were the sites that were the most impressive. And I think here it's in that joints and fascia, which is where the skin is involved, the fibrotic tissue. You can see here that the overall response rate was 75%, which is a very, we were very happy with that when I saw that. And this drug is very easy to tolerate. Does not have count checks. It's easy. The profile toxicity looks better than what we've seen with Jakafi and ibrutinib. The dosing, it is an easy dosing. Most patients will be on it once a day. However, if you are on a protein pump inhibitor, it has been dosed twice a day, and that's package insert says that. So moving on to talk a little bit about ECP, and then we're going to talk a little bit about the results from Rituxan. ECP is a very interesting approach to treating graft-versus-host disease. It's more thought to be immune modulating versus immunosuppressing. The patients are hooked up to a machine that looks very much like a pheresis machine, and their T cells are extrapolated, and they are then injected with this medication that photosensitizes them, and then the blood is then run through a machine, and they have UVA exposure, and it decreases the T cell population, and then they are reinfused. This overall response rate looks very good, between 50 to 65%. I will say that, it's a 2-hour process. Usually it's twice weekly, and then after response is seen, it can be tapered down. You do have to have a certain type of catheter is placed. So it's a little bit more invasive. It's not like taking a pill. I mean, you would have to have a catheter placed so that you can have access to this machine. But it does seem to work really well for chronic graft-versus-host disease. The response rate is very good, and we have actually started using it now some for acute graft-versus-host disease. However, you have to be at a center that has the ability to be able to operate this machine. It's usually a pheresis type center that would be able to perform this for the patients. The last agent that's worth mentioning is rituximab. We use rituximab quite a bit here. It is another second-line agent. However, it is given IV. It's administered every 4 weeks, and then as a maintenance schedule, it's given every 12 weeks after the initial induction of 4 weeks. It can cause Hep B reactivation. The drug was originally approved by the FDA to treat arthritis. It appears to have especially, beneficial in the skin and oral, as well as the musculoskeletal involvement. The response rate in the severe category is 86%. So I think that, it is a good drug. It's a good option. But keep in mind, you would have to come in weekly to get an infusion. You would have to have a line because this is given IV. And it can cause CMV reactivation as well as a neutropenia. So it just, the good thing about there's more options there now for chronic graft-versus-host disease patients, more than what we've ever had. I do want to end by saying that I have touched very briefly on the 3 new drugs, as well as ECP and rituximab, and that November the 10th, there will be another webinar that will be sponsored here, and it will be Dr. Noah Holtzman. He's from the National Institute of Health, and he's going to present the importance of new GVHD treatments, with the hope of maybe going in a lot more detail with some of the other newer things that are coming up.
Well, thank you so very much, Dr. Sizemore. This was very comprehensive and so appreciated. I will make one little correction, and this is my bad. We just did this. We changed the date from November 10th to December 15th. We needed a little more time on that one, and I apologize for not getting you that information. So everyone on the call, we will make sure you get an invitation, and we'll have another webinar in mid-December. So I will move right on now and introduce Dr. Don Stackheart, who will deal with the psychosocial aspects. Here you go, Don. It's all yours.
Thank you. So, what I'm about to talk about is the obvious parts that come with people who go through transplant and dealing with chronic GVHD, is that there is a psychosocial component. And just so you know, again, who I am, we're lucky enough here to have me as a dedicated program psychologist for the last 20 years or so here at Northside Hospital in Atlanta, where I have Connie and the other colleagues on this program, so that we can all work together in dealing with chronic graft-versus-host disease and just all of the transplant complications. So, when you're going through transplant, the obvious thing is you're looking forward to being done. And then all of a sudden, as Connie says, post day 180, when you should be thinking, am I getting back to work? Are things getting back to normal? Getting diagnosed with chronic graft-versus-host disease is very difficult. The emotions run the gamut, and mostly it's just frustration because the transplant process has been long enough. Why me? Why now? And how much longer will this go on? So usually people are very angry. There's a spiritual component. Why me? Could this happen to me? Why would this happen? Then people get very sad and very disappointed. I thought things were getting better. I thought I was almost done. I thought things were going to get back to normal, and they're sad and then scared, just like people are when they start the transplant process and you're not sure what complications are going to come up. How serious is it? You're scared again. What does this mean? Is this life-threatening? Is this permanent? Will I be okay? It's really important to get to the phase of accepting this diagnosis. Just like you accepted the need to go through a transplant, you have to accept that, hey, we've got chronic graft versus host disease, we've got to deal with it. It's important to avoid guilt and blaming, because the truth of it is that, as we heard in previous slides, people get graft versus host disease. It's just part of what happens. So as we come to terms with it, it's important to understand what it is, which we just heard all about, and what is your specific issue. As I'm reading through the questions, clearly people have issues with their eyes, their liver, their skin, their mouth, and you have to understand what yours is, and that your chronic skin graft versus host disease might be different than the next 5 people sitting next to you. And also, understanding this will help emotionally and physically as far as dealing with depression and different symptoms that can be worsened with anxiety and depression, like GI symptoms. It's important to ask your treatment team and understand, is it going to go away? How long will it take to go away? Will it come back? Am I worried about it coming back as I taper off the medications? Understanding and asking some of these questions will be helpful in preparing yourself for what treatment plan will be right for you and what's going to happen in the future. As far as coming to terms with the diagnosis of chronic graft versus host disease, it's important to get treatment. Like a lot of the lung issues and other issues, the sooner we find it, the sooner we can get rid of it, and the easier it is to treat it. If it's left untreated, it can lead to a decrease in quality of life, a decrease in physical functioning, and an increase in these chronic GVHD symptoms. So we understand that all of our patients want to be done with the transplant process. We totally understand that, but we can't ignore chronic graft versus host disease. Survivorship from transplant is very difficult. When people are diagnosed with chronic graft versus host disease, they often feel very alone. You've gone from being seen by your transplant program frequently to less frequent visits. It's harder to feel like people are still thinking about you and caring about you when you're seeing them once a month versus 5 times a week. So you can feel rather alone. It's also very hard to find people who understand what you're dealing with. As hard as it is for family and friends to understand what the bone marrow transplant process is like, it's even harder to explain chronic graft versus host disease, especially things that they can't see, like eyes, mouth, and different skin areas. And it's hard to understand yourself, what does the future hold? Nothing that we do in transplant is black and white. There's shades of gray. So it's just a hard process. The best way to deal with chronic graft versus host disease, and again, this sounds like obvious information, as we would tell you before transplant, but they're essential. You have to build a support system. You have to have friends, family, people that you can reach out to, talk to, ask for help, even if you're not going to discuss, hey, my eyes are really dry, but you know you need help, you need a ride, you need transportation. Also support groups. One thing about transplant is that the only people that really understand transplant and chronic graft versus host disease are people who live in this world. We're in a very, very specialized area, and people don't understand. So there are a lot of online group options specific to bone marrow transplant and graft versus host disease where you can talk to somebody else who's gone through it, who's had skin GVHD, who's had chronic GVHD. Maybe what they're doing doesn't work for you, but maybe it will. And maybe just talking to them is important because it lets you know that you're not the only one out there. There's also a change in relationships. Intimacy, it just changes with the prolonged chronic illness course of getting chronic GVHD after transplant. You might need treatment to help with your mood or physical symptoms to help with intimacy. And these are very important things to point out to your care team so that we can address whatever it is that's impacting your relationships. There's also practical problems. We're well aware that patients going through transplant can't work. If you're dealing with chronic graft versus host disease, depending on what your issues are, you may again be told you cannot return to work. You will also then accrue more medical bills. It's a practical problem. Also, prior to transplant, you may have been the primary care for children or for elderly parents and have been expecting it 5 months, 6 months, 7 months after transplant to go back to this role. And with chronic graft versus host disease, you may be unable to care for children or elderly parents, and there may be a delay in returning to your role that you had prior to transplant. So the hard part of chronic graft versus host disease is that life feels very uncertain. You feel stuck. It is the whole, when you're going through transplant, I can see the light at the end of the tunnel. You get chronic graft versus host disease, and you don't see that light sometimes. It's there, but it's harder to see. And the question is, when will it end? How long will it take to end? I feel stuck, like I'm doing the same treatment month after month with very minimal improvement in my symptoms. Sometimes it's great, sometimes there's a little setback, and you just feel stuck. It's so important to keep that same positive attitude you had prior to starting transplant. I know you're tired. I know you don't want to anymore, but this is still the same fight for your life in that your whole goal is to return to some sense of normalcy, your life before transplant, before your diagnosis, and to live for the next, 30, 40, 50, 60 years enjoying everyone around you. So you do have to get back to, I can see that slight light at the end of the tunnel, and keep that positive attitude. It is so important to build that support system. Just like with transplant for chronic graft versus host disease, you have to have that support system. You also have to find a purpose. Prior to transplant, you had a job, you had a family, you had a crossword puzzle, whatever it is you had that you did every day, you need purpose still. Volunteer, help others, learn to knit, make blankets, whatever it is that will give you purpose each day. And then seek activities that you can do that increase quality of life. Read a book to your grandchild. Go for a walk. Have a conversation with your mother. These are all things that will increase your emotional and physical quality of life. And just like with transplant, you need to stay present and mindful every day. When patients go through transplant, we say, you know what, it's a good day. I can walk, I can eat, I can breathe fresh air, I'm doing well. So now, same thing applies. Today, I'm awake, I'm alert, I'm going to work, I'm spending a day with my daughter. Whatever it is, stay present, mindful. There are positive things happening every day. Also, continue with healthy habits. Diet, exercise, sleep, these are all important things, not only to keep you emotionally well, but to help with healing and getting better physically. And then I can't say enough about this, but be compliant with your chronic graft versus host disease treatments. I know you're frustrated. I know it's taken too long, but don't miss a pill. Don't miss applying the lotion. Don't miss eye drops. Whatever it is that you're supposed to be doing, we need to continue doing. We need to stay ahead of the problem. We need to continue treating it so that we can minimize symptoms and get everybody better. It's very, very important to be compliant with your treatments. I will also encourage you, you have to reach out to your treatment team. I know sometimes we don't look like we're paying attention or we're actively asking questions, but we do want to know what's going on. We want to know what your symptoms are. If you have a physical complaint, let us know. If you have an emotional complaint, let us know. Let your treatment team help with what we can help with. Don't be shy. That's why we're here. When you come back for your visits, let us know what's going on. And be patient. Be patient with yourself and be patient with us as your treatment team. We're all working towards the same goal. And we want to, help you. So don't be shy. Reach out and let us know what we can help with. And I'm going to end with that.
Well, thank you so much, Don. That was fantastic. A lot of great coping skills, and we appreciate it. We're going to move right on because we got to cruise along here, and we have Latasha next. Latasha, your turn.
Hello. I'm going to go ahead and navigate my slides here. Hello, everyone. My name is Latasha, and I'm the GVHD nurse for the bone marrow transplant program here at Northside Hospital. And I am one of one, meaning that I only do graft versus host disease assessments and staging and grading for the program. So to get started, I want to let you all see some pictures here. And these pictures on the right show skin GVHD and oral GVHD. I use an assessment form to stage and grade graft versus host disease. And I like to start with the skin. That is the first one on the assessment sheet. And it is the largest organ in the body, on the body, so I like to start there. Typically, some of the hallmark signs for chronic GVHD of the skin is dry skin, limited mobility, rash, sores, and ulcerations. So I typically have the patient show me all parts of their body as far as skins, arms, legs. I want to know what does it feel like? Is it tight? I'm looking for discoloration within the skin, the texture of the skin, pigment changes of the skin. And I use the patient to tell me what they feel. So it is a subjective component and also an objective component to this assessment. The mouth, as you see here on the slide, some patients do develop oral ulcerations. They develop sensitivity to spicy foods, acidic beverages, carbonated beverages, acidic foods as well. So I'm always asking patients about their diet. What does it feel like inside of the mouth? And most importantly, I do an oral exam of the mouth. The patients are sometimes able to tell me that even small things like toothpaste or their mouth rinse is burned. So it's not limited just to foods, but just oral care in itself. Patients will notice a change and they're able to let me know along with the ulcerations. The oral side is not just limited to the inside of the mouth. We also do examination of the outside of the mouth. So if the lips become very chapped and very dry, they can also crack and cause some ulcerations there as well. Moving on to our next slide. Here we focus on the eyes. The eyes is another component where it's objective and subjective, and I also have to include the multidisciplinary team for help with this, because when the patient has dry eyes, we do have to send them over to an ophthalmologist for an exam. A lot of times, as Connie said, we can go ahead and move forward with the exam here, and we can administer some medications, but a lot of times we do have to get the patients to an ophthalmologist so that they can be examined further to see what else they need to manage their dry eye symptoms. But some of the hallmark signs are simply dry, burny, and gritty eyes. Sometimes there are pain associated with that, sensitivity to light and to wind. Sometimes patients do have diminished visual acuity, so it's very important that patients are assessed when these clinical manifestations first start so that we can get them treated appropriately. Another area on this slide that we assess is the GI tract. And with the GI tract, I assess the patient to see if they're having any nausea, vomiting, or diarrhea, any weight loss, any abdominal pain and cramping. Those are very important signs of a patient that could be having some clinical manifestation of gut GVHD. Okay, so we're looking at lots of things, and in fact, we do think that the patient may have some symptoms. Patients are asked to have a colonoscopy or EGD to assess those signs and symptoms. Another area that we look at is the liver. The liver is staged and graded based off the liver function enzyme. So we're looking at total bilirubin and other functions of the liver enzymes to see if the patient has some clinical manifestation of liver GVHD. Also looking at the patient's skin for jaundice, looking for itching, fatigue. So diagnostic testing, we do labs, but we also sometimes have to have a patient do a liver biopsy to assess that. Another area that we look at is the lung, and Connie did a great presentation about the lungs and how important it is. So we do use the pulmonary function test before the patient goes to transplant as a baseline, and we use that test at each post-transplant restaging as well to assess if there's a decline with the patient's pulmonary function. But again, I rely on the patient to tell me too if they start to experience any shortness of breath. And then too, we have to send the patient sometimes to a pulmonologist to help manage further symptoms that the patient could be experiencing. On my next slide here, I'm going back over to the skin and the joints and musculoskeletal area. When I do my assessments on the patient, I also look and have them explain to me if they're experiencing tightness, which is sclerotic features of the skin. It can also be in the joints. So here you can see on examination, some patients will have some dimpling of the skin, hyperpigmentation, some range of motion that is very limited when they try to stretch, or when they try to make a palm-like prayer hand. There can be some tightness in the wrist and the fingers area, the shoulders, and also the elbow area. So I'm always assessing those areas to make sure that if there are some scleroderma features, that we go ahead and get those patients on systemic treatment so that we can manage those symptoms, because scleroderma can be very debilitating to the patient. The genital area is another area that we also assess, and it can be very difficult to assess the genital area in the sense that we do not do pelvic exams here on females. We do have to refer those patients out to a gynecologist. So I rely on the patient to simply tell me if they are having any irritation in the area, in the sense where they have lots of dryness, or if they have painful intercourse, painful urination, burning or itching in the area, because sometimes the vagina can have some closure in that area. So we send the patients out to a gynecologist that can assist with monitoring and treating those patients. For the males, we can do a visual exam, but we would have to send the patient to a urologist if there was some surgical intervention that needed to be had with those patients. In closure, I would like to say that, having chronic graft versus host disease is not an easy journey. The earlier the patients can tell the team about their clinical manifestations, the earlier we can get in and start trying to get these symptoms managed. I have asked my patients to go ahead and start doing a diary of their symptoms, meaning not that they write down in a journal per se, but if you notice that you have dry eyes, start documenting how often you're having to put your drops in, what your signs and symptoms are. If you're having changes within your skin, go ahead and start taking pictures of your body. If you notice tightening, take pictures of your range of motion. Also, keep a diary of your labs, your complete blood count, your liver function test. And then most importantly, make sure you follow up with your long-term follow-up care. It is so important that if you are going to see an ophthalmologist, that you keep those follow-up appointments. If you are having some oral GVHD, that you keep your dentist appointments. There may be a need to do a oral biopsy. Dermatologist, it's so important that patients that have had a transplant, that they are seeing their dermatologist at least twice a year so that they are getting their skin assessed, and we're looking for other forms of cancer. The pulmonary function test, we do those at each post-transplant restaging, so we need for the patients to complete those because it's so important. Getting vaccinated is so important for the immune system. So when the physician or the treating team tells you that it's okay to go ahead and get vaccinated, it's important to do that because this is going to help build your immune system back, make the bone marrow stronger again, and get you in a place where you're able to fight off infections better. Again, it is just so important that when you are educated about clinical manifestations, about chronic GVHD, that you are able to articulate those features and let us know when you have the initial onset. The sooner the better. Treatment will not always be the same throughout the journey, but it's important that if it's getting worse, that we're able to change things so that we can provide you with a better quality of life. Thank you so much.
Wow, well, thank you, Latasha. That was fantastic. Okay, so now we have our wonderful patient, voice Lisa, and I just want to mention that we are going to go a little bit over because there are so many great questions. And for anyone that has not had their question answered by the time we finish, I promise you, I've been writing them all down. We will get back with you with answers. But if you guys can hang in there a little bit after 1:30, we'll try to get it all done. So now I introduce to you Lisa of California.
Hi, everybody. Thank you so much for listening, and thank you for all our previous presenters for such great information. I'm 58, born and raised in California, the San Francisco Bay Area. Beautiful sunny day today. The mom of two young, beautiful ladies who now live locally after my illness, but we love to travel. We love the outdoors. I love the outdoors. I love walking, gardening, and managing my vineyard where I grow about 110 grapes. I was also a teacher before in my previous life. I call myself an innovating teacher. Loved flexible seating, love the kids, love the outdoors. You can see me teaching outside and the beautiful landscape where we were located near some open space. And then I was just living my life and whammo. I wasn't feeling so great in December of 2019. A lot of fatigue, cough, fevers. January 2020, went for a couple different doctor's visits. They gave me cold medicine or recommended it. Finally, we got some blood work done, and on January 29th of 2020, I had a bone marrow biopsy and admitted to the ER and then to the hospital for treatment. That day, I got a call from my doctor. I was at work, and I had a feeling it wasn't good. I remember driving home and asking my then boyfriend, now husband, to take me to the hospital. And I was admitted on January 29th, right after the bone marrow biopsy, and I didn't go home for a month. They said, you've got AML. So first I had rounds of chemo. I was in the hospital for a month in February into March. Meanwhile, they said, you'll need a bone marrow match. We'll need to do a transplant. So they went out searching for my match. We got a match very quickly, probably by March, I think we knew. And then they started talking about the graft versus host disease and some of the effects of the bone marrow transplant. It was all kind of a blur, and listening to podcasts like this and just educating myself after, I kind of understand it. When you're in the throes of the illness and not understanding exactly what's happening, it's a little overwhelming. Well, I was ready to fight, completely lost my hair, which I know Peggy knows that I had mentioned earlier was kind of a cancer benefit, very invigorating to be bald and then come back with some really cool gray hair. But I was ready to fight, and in March 2020, like I said, the match was found. And May 2020, I checked into Stanford Hospital for more chemo and the transplant. And of course, it was the middle of COVID, deep COVID, and I can describe it as almost feeling I was being dropped off at summer camp in front of Stanford Hospital with my duffel bag and my pillow, and didn't see my family for probably 30 days, except for via video chats. So I had my transplant on May 20th, 2020. The cells that saved me, it was a little anticlimactic. Just with having the Hickman port, the cells came in that little bag, and it hung on the IV pole and dripped into my body to I guess, considering to give me new life. The nurses gave me a little party that night with a cake and my mask for the next 100 days, and anybody else who's had the transplant knows about these masks. And of course, the GVHD did set in right away. And I know the previous speakers talked about it. Skin was my biggest issue. The first picture is probably about 30 days after the transplant. And then it progressed, got better. I was on a few rounds of steroids, tacrolimus ointments, and orally. And today, the picture with the hat on, I still suffer from some face GVHD, and you can see that red cheeks. But it's kind of my badge of honor. The way I handle this and live my life now as a sunny California girl with a beautiful yard and vineyard and all my life working outside, I do it with hats and more hats. And I just showed a picture of my SPF hats hanging up, my SPF shirts. I bought some great sunscreen. I don't go anywhere without it. And I've just continued to live my life. I do have some joint issues. I was, again, on a dose of steroids for that last year, kind of nipped it in the bud, and still feeling that general fatigue that I think many transplant patients feel. My life now, again, it's hats and sun shirts. I still head outside. Again, like I said, it's beautiful California. We bought a fifth-wheel trailer last year, gave me some safe travels, I think I should say, because we are self-contained. I didn't have to worry about seeing or being near people in the COVID world. And I continue to work outside in the yard. Again, the hat, the sun shirt, it hasn't really slowed me down. It's really kind of my therapy. And I know that Don talked a little bit earlier about finding purpose and living life despite these side effects we have from the transplant. And that's what I continue to do. So today I just want to end it with that idea of fighting this cancer and fighting the side effects of the transplant. Keep fighting. Reach out to your team. Find your people. Find people on Facebook in groups. There's GVHD groups. There's acute myeloid leukemia groups. All sorts of groups that you can connect with and talk to people so that you aren't alone. Give yourself time. Take each day. Love it. Join groups, like I said earlier, your local cancer community. Talk to people about it. I'm enjoying my almost 1 year anniversary of being married. That's our wedding picture. We married last December, and I relish life every day. And so glad to get to share my story with you. Thank you so much.
Wow. Well, Lisa, what a perfect way to end this presentation. I've got a lump in my throat, a good lump in my throat, and I thank you. I think you are a complete inspiration, and I hope everyone on the call feels that today. So let's dig right in. We've got some questions. I'm going to fire away if it's okay. Or Kevin, are all the questions in the queue, or are there others coming in?
Not at this time. All questions are below your slide deck.
Okay, perfect. So I'm going to dig right in. Curious what the success rate is looking like for patients with Resurrect. What GVH does it treat best? So Dr. Sizemore, I think you may have covered this. Is there anything you want to add to this question?
Yes, I can make a statement about this. I think that where we are all very hopeful for Resurrect is in that scleroderma fibrotic patient that has, whether it's fibrosis of the lung or skin. I just recently had a patient that has severe fibrotic tissue in her vaginal tract to the point that she had been recommended to get a vaginal reconstruction surgery, and we're trying Resurrect in her. So I think that the patients that I have tried it in thus far, we've been very pleased with the results. I have a patient that she had scleroderma of her skin, and she's been on it for about 5 weeks, and we're starting to see a little bit of the skin flexibility. So I think it's a very hopeful drug to, for the patients that have had multiple lines of therapy. But to answer your question, I mean, it looks like it's going to be very good for those patients that have joint skin issues. So we're excited to see how this works out for patients.
Terrific. Thank you so much for that. Okay, we got another question. I know I'm gonna butcher this word, but I'm gonna try. Are there GVHD solutions coming from the Ayurvedic medicine or homeopathic communities? Not sure who might want to take that one. Dr. Sizemore, any ideas?
Yeah, I mean, I think that, everything is clinical trial based, right? So I haven't seen anything on homeopathic use for GVHD. I will say for alternative medicine, when you have skin involvement, you have your paraffin wax. I've recommended that before. It helps to soften the skin. You've got stretches, yoga. You have your any type of yoga exercises that are Pilates, things that you can do at home. I don't know that if you're on immunosuppressant therapy, you should be going to Pilates studio, but I mean, there are alternative things that you can do, especially for those joint issues for skin tightness. I think meditation feeds into what Don has mentioned as well. So I don't know that there's anything particularly with GVHD in this issue because I haven't seen anything, but we do have and we do recommend alternative therapy that is non-medicinal.
Great. I know we had someone ask about liver GVHD, and I know that it was covered a little bit. Is there anything you might want to add? Her daughter has it regarding the liver issues.
I will say that, as far as liver GVHD, you can, in all the clinical trials that ibrutinib, Jakafi, as well as Rezurock, there was patient population that had liver issues. It may require limitations because of some of these drugs you have to do dose reduction if there is severe liver impairment. Jakafi particularly does have a liver GVHD dosing. For us, we have used rituximab and had very good success with that. I would recommend. There is data for that as well. It's hard to say without knowing what other lines of therapy that have already been tried for liver GVHD. You just have to be careful, with your mold coverage because most of your antifungals, noxaphil and defend, they are cleared by eliminated through the liver. So a patient who has liver GVHD would require an alternative such as either Cresemba or micafungin for antifungal prophylaxis if they have liver GVH.
Terrific. Thank you so much. We got a few questions about Sclera Lenses. One person says, they've been a lifesaver for my eyes. However, my eye doctor suggested to use saline drops in the lens rather than refresh drops or autologous serum drops. Should I switch?
I think that is, it's hard for me to say. I know for us that we use the autologous drops in our lens because it's your own serum, and it's a little bit thicker than some of the other solutions that are there is a thinner viscosity. So it all depends if you're able to obtain those autologous drops. You do have to have a compound in pharmacy that you can take the serum blood to, and that can put the drops in a dropper for you. The one thing that patients do like about the autologous drops is that they are refrigerated, and it does feel nice to put the cold drops on your eyes. But I think, maybe readdress it with your ophthalmologist and see what his thoughts are about that.
Well, thank you so much. Okay, here's one. Have you ever heard of chronic graft versus host disease of the tympanic membrane? I had started having hearing loss, and the ENT found my TM to be very thickened with sclerosis fibrosis. I have GVHD of most of my other symptoms, eye, mouth, lung, liver, skin, muscle, vagina, etc., 5.5 years out of transplant.
Wow. No, I have not, but I mean, I'm not surprised. I mean, there could be, if you have, it sounds like there's extensive mucosal in your mouth area that's involved. I'm not surprised. I would think that you could use a steroid eardrop. That might be a solution. I don't know if you've tried that, but sometimes it's trial and error when you have chronic GVHD that you have a site that's not common. So I would maybe see if your ENT would feel okay about doing that, putting you on. They do have eardrops that are a steroid. So that might be an option. And it may be an option to put a tube in there so that the steroid could get to that area.
Okay. All righty. Dawn, are you still on the line?
Yes, I'm here.
Drop off.
I'm here.
Okay, I'm gonna ask you about a fatigue question. Is severe fatigue years after transplant an independent type of chronic graft versus host disease? And is there any management apart from like self-care, such as exercise, sleep, good nutrition?
Well, I mean, and I'm going to let Connie also talk about, because there is some muscular chronic GVHD, but one of the main things, and even Lisa can talk about, is, you're just tired, and emotionally, it's exhausting. And so a lot of patients feel more tired when they're trying to go back to work. They feel more tired when they're getting back into their daily routine. They feel more tired. And this transition from transplant patient back to real life, which everybody at the beginning is waiting for, is a lot harder of a transition than I think patients expect it to be. And there are some lingering side effects, even if your chronic graft versus host disease is getting better, just with the medications that you're taking. So that's why we, as we say, we talk about healthy behavior, getting good sleep, getting good diet. It's all this big circle. But I don't know, Connie, if you want to talk about, there is some muscular chronic GVHD that could also impact, I don't know if it's fatigue, but maybe pain or weakness. I'm not sure if that's a...
Exactly. And I think that, it's hard sometimes to decipher, is it one, the steroids that's caused, steroid myopathy, and maybe, especially for those patients who have lung GVHD, steroid myopathy, because you're on steroids for 4 to 6 weeks. So I think it's hard to distinguish if it's steroids or if it's some other drug that could be causing it. I think, Dawn had mentioned about just getting yourself on a routine. Physical therapy helps. I think that meditation, yoga, things like that definitely help them with some of that fatigue. What I have used in the past when a patient who says, well, I am so tired, I don't even want to go to physical therapy. I can't even get up and go. I've used a low-dose stimulant like Ritalin in the morning, and that is just enough to get these patients up, to give them the energy to push them to go to physical therapy. And, after 2 to 3 weeks, and once the muscles become stronger, they don't need the stimulant. And I think naps during the day. I mean, that's the other thing I tell some of these patients is, you have to look at it like you have chronic GVHD, you get up, you work, you come to the clinic or do things around the house, take an hour nap, and then go back and finish up the rest of your day.
Sounds good. I remember one patient telling us that he thinks of himself as a cell phone battery. In the morning, he's fully charged, and he takes on the things in his day that are going to take the most energy, and then he reminds himself that at the end of the day, he's going to be low on battery. And I just think all of us should remember that in our lives, especially people struggling with chronic graft-versus-host disease. So I have another question. No one has mentioned about having pain in the skin. I have significant pain to the touch of my skin, but my doctor tells me pain isn't common with chronic graft-versus-host disease. Even taking PB hurts. Can you comment if other patients experience the same? Maybe Latasha would want to take this one?
Yes, I can. I have assessed some patients that certainly tells me that when I am palpating their skin in certain areas that it is painful. Now, not everyone, but just certain patients. Now, doing the skin assessment, when I talk to patients, it's not a hallmark sign of chronic GVHD of the skin, but I have certainly had patients to tell me that when I touch them, it hurts. So I've certainly heard it from some patients. But a patient that has ulcerations and lesions that are open, they definitely experience pain. And that has to be treated with pain medication. So that, and also, of course, antibiotics and so forth, so we can heal those areas. But I've certainly heard it. I've been told it.
Well, thank you so much. Would you professionals like to keep going? Do you have a few more minutes for a few more questions, or do you think we should close it up?
I'm available for more questions if there are any that pertains to me.
Dr. Sizemore?
I can go a few more minutes, yeah.
Okay, let's do one or two more, and then we will call it a day here. Someone says, great question. I also don't see any mention of renal involvement with chronic graft-versus-host disease. I'm 7 years post-transplant, developed chronic kidney disease that has now advanced significantly and cause is still unknown. Thought it to be possibly related to myeloablative radiation regimen or possible cGVHD. How common is renal involvement with chronic graft-versus-host disease?
It is not very common at all. However, I have had a patient that had renal involvement of the nephrostomy tubes. There is a publication. I was trying to find it, and it's somewhere in my database here. I can maybe send it out to you, Peggy, and you can send it on to that patient. But you can do a biopsy. It might be worthwhile to do a biopsy to confirm that that is definitely what it looks like as GVH. But, patients go, especially if you're on tacrolimus, it is very damaging to your kidneys. Ganciclovir, Ambizone. There's several drugs that you could have potentially received that did damage your kidney tubules. So I think that it is hard to distinguish whether it's just from potentially the myeloablation transplant, the chemotherapy, the drug therapy, but a biopsy would be a start. And then I will try to find this paper because I'm pretty sure in this paper we used rituximab. That was the treatment, but I will look for it and send it on to you, Peggy.
Oh, thank you so much. That's terrific. Let's close out with one more question. This is from Zach. Will the chronic GVHD in my mouth go away with clobetasol treatment, or will I need to use the topical steroid every day for the rest of my life?
Ideally, clobetasol is in that high potency category. I would not recommend using it forever and ever. What I like to do is initially I have patients use it all over, and then typically what happens is the lesions in the mouth, they become smaller, and then what I do with that is I use a gauze pad and just apply, put the steroid on that gauze pad, and then you can stick that gauze pad exactly where you have the lesions in your mouth. If you've been using clobetasol for 4 weeks and you're not seeing a change at all, it's time to change therapies. You would not want to continue to use it forever and ever because it can have potential to cause mouth cancers as well. So it's not an agent that I would keep using, but I have, you might want to try, if you just have one area, local area, to put it on a gauze pad and then stick it on that area, because that way you can get concentrated drug just to that area.
Well, thank you so much. My goodness, what a wonderful program. And I just can't say enough about the speakers. And I thank our link partners and our sponsors, Insight Corporation and Pharmacyclic and Jensen. And I will look through all the questions and try to get back if there's anything we missed. But I think we did a pretty good job on that. And again, I'll be sending you all a survey, and please reach out to us. Let us know what else you want to learn about, because we are here to help you, and everything we do is because of you. So thank you all, and have a wonderful afternoon.
Thank you. That does conclude today's teleconference and webcast. You may disconnect your line at this time and have a wonderful day. We thank you for your participation today.